Let's get right into this explainer on Step 2 CK, high-yield diabetes logic. We're covering everything from diagnosis and emergencies to specific management pathways.
Our agenda covers 6 main areas: diabetes diagnosis and subtypes, DK and HHS management, the hypoglycemia workup, outpatient escalation and medication traps, the inpatient glucose protocol, and finally, diabetes health maintenance screening.
Section 1. Diabetes diagnosis and subtypes.
Making the diagnosis means you have to hit specific thresholds. You're looking for an A1C of 6.5% or higher, a fasting glucose of at least 126, or a random glucose of 200 or more if the patient is actually showing hyperglycemic symptoms. There's also the 2-hour oral glucose tolerance test, which also has a cutoff of 200. Keep in mind that oral glucose tolerance test is especially useful if you're evaluating polycystic ovary syndrome because it's actually more sensitive than just checking fasting glucose or an A1C.
Now, you have to separate type 1 and type 2 diabetes based on their underlying mechanisms. Type 1 is defined by autoimmune beta cell destruction, resulting in an absolute insulin deficiency. These patients are usually younger, leaner, may have other autoimmune diseases, and carry a distinct risk for diabetic ketoacidosis. Type 2, on the other hand, is driven by insulin resistance with a relative deficiency. You'll classically see this in patients with obesity, acanthosis nigricans, hypertension, dyslipidemia, or fatty liver. And their primary risk, that's going to be hyperosmolar hyperglycemic state, or HHS.
Section 2. DKA and HHS management.
Timing is your major differentiator on the exam. DKA develops rapidly, usually over just hours. It often happens in type 1 diabetes or even as the very first presentation of the disease. It progresses quickly from polyuria, polydipsia, and blurred vision straight into abdominal pain, vomiting, altered mentation, and those deep, rapid Kussmaul respirations. HHS, however, is a subacute progression over days to weeks, almost always in type 2 diabetes. It leads to profound hyperglycemia, hyperosmolarity, severe dehydration, and altered mental status. But the key here is you'll see minimal ketosis or acidosis.
Looking at the lab pattern for DK, you'll usually spot a serum glucose somewhere between 300 and 800. Labs are going to show an anion gap metabolic acidosis with a bicarb under 18, right alongside positive serum ketones. When you recognize that specific triad, it's your immediate cue to start the emergency management sequence.
That management sequence is strictly stepwise. Step 1 is fluid replacement with isotonic IV fluids, typically normal saline. Honestly, this is also your most crucial first step for HHS. Step 2, you absolutely must check potassium before giving any insulin. Step 3 is initiating the IV insulin infusion. And finally, Step 4 requires you to add dextrose to the IV fluids the second the serum glucose drops below 200. This prevents hypoglycemia while the insulin keeps working to close the anion gap. Let's talk about those strict exam rules. If potassium is below 3.3, you hold the insulin and replace the potassium first. If it's between 3.3 and 5.3, you replace potassium while giving the insulin. To monitor resolution, don't rely on a standard urine dipstick since it only picks up acetoacetate. Instead, use a direct assay of beta-hydroxybutyrate or watch the serum anion gap. And bicarb replacement? That's extremely rare. Only consider it for severe acidemia with a pH of 6.9 or lower. Finally, when you're transitioning off the drip, make sure to overlap IV and subcutaneous insulin for 1 to 2 hours so you don't trigger rebound ketoacidosis.
Section 3. Hypoglycemia workup and labs.
Hypoglycemia symptoms generally fall into 2 buckets: adrenergic, like tremors, palpitations, and sweating, or neuroglycopenic, like confusion, seizures, or even passing out. But here's the rule. A formal clinical workup is only indicated when the Whipple triad is fully present. That means symptoms of hypoglycemia, a low blood glucose measured right when symptoms occur, and relief of those symptoms when the glucose goes back up. Always confirm low values with a standard lab assay because capillary fingersticks are notoriously unreliable at the lower extremes.
Now, if you're evaluating spontaneous hypoglycemia and it's actually safe to delay treatment for a moment, you need to do a simultaneous lab draw before any glucose is administered. This draw has to include serum insulin, C-peptide, proinsulin, and a hypoglycemic drug screen. That specific panel is exactly how you differentiate endogenous hyperinsulinemia, like an insulinoma, from someone taking exogenous insulin or secretagogues.
Section 4. Outpatient escalation and medication traps.
Progressive therapeutic intensification in type 2 diabetes is very logical. Metformin is your preferred initial therapy, unless there's a contraindication. The next best step is adding an SGLT2 inhibitor or a GLP-1 receptor agonist if the patient has cardiovascular disease, heart failure, chronic kidney disease, albuminuria, or if they would benefit from weight loss. If the A1C is still persistently high, you add basal insulin. And if their fasting glucose gets controlled but that A1C remains elevated, that's a sign of postprandial hyperglycemia, meaning it's time to add rapid-acting mealtime insulin.
Watch out for this classic exam trap: continuing oral agents in acutely ill patients. Metformin and other oral anti-diabetic drugs are strictly contraindicated if the patient has a severe illness, like sepsis, if they're having major surgery, or if they have acute renal failure. The reason is the high risk of lactic acidosis and altered renal clearance. In these scenarios, you stop the oral agents immediately and transition the patient straight to insulin therapy.
Section 5. Inpatient Glucose Management Protocol. Getting into the hospital protocol, it demands you classify the diabetes type, evaluate illness severity, and figure out their dietary status. Are they eating normally, eating less, or strict NPO? Most hospitalized patients are going to have their oral drugs stopped entirely, but listen closely. Never stop basal insulin in a type 1 diabetic patient, no matter their dietary status. You have to keep it going to prevent DKA.
For eating patients who need optimal scheduled control, you'll use a basal bolus regimen, combining long-acting and mealtime rapid-acting insulin. Sliding scale-only regimens restrict those to initially well-controlled type 2 patients, and you reserve continuous IV insulin infusions for the critical situations, hyperglycemic emergencies, perioperative or laboring type 1 patients, or those who need ICU-level care.
Section 6. Diabetes Health Maintenance Screening.
For outpatient glycemic control, you're monitored by checking the A1C every 3 to 6 months. Systemic complications need strictly scheduled screening based on the modality. For type 2 diabetics, you start this screening the moment they're diagnosed. For type 1 diabetics, complication screening usually kicks off 5 years after their initial diagnosis.
Here are the screening requirements you need to lock in. Screen for nephropathy using an annual random urine albumin to creatinine ratio, and check their serum creatinine periodically. For retinopathy, they need a formal dilated eye exam every 1 to 2 years. Neuropathy screening means you're doing a visual inspection of the feet at every single clinical visit, plus a thorough monofilament foot exam once a year. Finally, cardiovascular risk has to be managed aggressively. That means annual lipid and blood pressure screening, strict lifestyle counseling, and getting them on statins and aspirin when it's clinically indicated.